Welcome to our attendees who have joined us today, and to those joining via the recording to the North Simcoe Muskoka Specialized Geriatric Services Practice Short for April 2024. My name is Stephanie Saunders, and I'm one of the psychogeriatric resource consultants with the North Simcoe Muskoka Geriatric or Specialized Geriatric Services. We'll just start this morning off with land acknowledgement. So we are gathering on traditional lands sacred to many Indigenous nations. I would like to acknowledge the traditional territory of the Anishinaabe, which include the Odawa, Ojibwe, Potawatomi nations, collectively known as the Three Fire Confederacy, the Haudenosaunee and Wendat nations, and the presence of First Nation, Métis, and Inuit residing in the Simcoe Muskoka territory. Most of us have come here as settlers, immigrants, or newcomers in this generations or generations past. We are all treaty people. As such, we commit to collaborating based on the foundational assumption that Indigenous people have the power, strength, and competency to develop culturally specific strategies for their communities. We are dedicated to honoring Indigenous self-determination, history, and culture, and are committed to moving forward in the spirit of reconciliation with respect to all First Nations, Métis, and Inuit people. We are pleased to provide our practice short through Zoom webinar. All participants are muted and videos are off. Please note that there is a chat box at the bottom of your screen for you to share with other participants. There is a question and answer section where we will ask you to write any questions for the speaker. We will be answering questions at the end of the presentation if we have time. Please do not click on any of the links in the chat box unless they are provided by myself or Jackie Esau or Allison Jayawara. And today's session is being recorded and will be accessible on the SGS website. If you are watching the recording, welcome. And a reminder, if you would like to join live, practice shorts are offered the second Friday of the month at 8:30 a.m. So I am very excited and pleased to be able to welcome Monica Menocola for our presentation this morning. Monica is the Regional Integration Lead for Osteoporosis Canada, and I'll let Monica take it away.
Thanks, Stephanie. I'd like to also welcome my colleague Judy Porteous, who's with me today, who does the regional integration lead role in Grey Bruce area, but covers, because of the way in which our region works, she has part of the Simcoe County Grey Bruce area. So thanks, Judy, for being online with me, and she'll be available to help with questions at the end as well. So I work for the Ontario Osteoporosis Strategy, as Stephanie mentioned, and it's funded by the Ministry of Health to really look at the prevention and reduction of hip fractures in the province of Ontario. It's been around since 2005. We have many provincial partners, as you'll see on the slide. And then at a regional level, each of us regional integration leads have partners as well. So many of you on the call today would be what I call my regional partners in the role of working to prevent fractures in the region. And so this is great to be able to present on the practice short today about the new osteoporosis clinical guidelines and talk about how they can be embedded in your work. So the objectives for today really is to learn about osteoporosis. Many of you know and have heard me speak before about osteoporosis, the fragility fractures and the consequences. I also want people to learn who's at risk of fractures and the importance of the prevention of fractures in the older adult population, and what you can do in your role in helping to integrate fracture prevention into your work. To share a brief overview of the 2023 clinical practice guidelines. And it's really going to be brief because we only have less than a half an hour, but I'll give you some resources so that you can reach out to get more details, and also talk about the long-term care fracture prevention recommendations. And then you will receive resources about fracture prevention and osteoporosis that you, for yourself, as healthcare providers, and also for the people that you work with, both older adults and their care partners. So what is osteoporosis? Well, it's very simple. I always say to people, it's osteo means bone and porous, obviously poor. So it's a condition which bones become thinner and more fragile, making them more likely to break or fracture. And I think I put both words here because people often say, well, I've just fractured, I didn't break. Well, breaks and fractures are the same. And so they cause that's the life-changing piece of osteoporosis is that actual fracture or that break. People live well with osteoporosis as a disease, but it's the fracture, that broken bone, that's life-changing. And that's what we are here to do, is to prevent fractures so people can live well and age well. Osteoporosis is a silent thief, so often people don't know that they have osteoporosis until they may have a fracture. So it sneaks up on people. That's what makes it difficult often for people to be thinking about their bone health, because it's not on their radar, because it is often asymptomatic. And the other thing I just want to mention is sometimes when we're working with our older adults and they hear the word osteo or osteoporosis, they get it confused with osteoarthritis or some of the other conditions. And so it's important that both for yourself and for us as individuals living with different chronic conditions, that we understand that and share that, yes, it's osteoporosis, and it's not osteo, and that it's very different than osteoarthritis, for instance, which a lot of older adults deal with as well, which is the wear and tear of our bones versus the actual fracturing. So the incidence of osteoporotic fractures, well, 1 in 3 women and 1 in 5 men will have an osteoporotic fracture over the age of 50. For women, osteoporotic or fragility fractures are more common than heart attack, stroke, and breast cancer combined. So the incidence is very high. So we see about roughly 57,000 fractures in Ontario every year. And of those, 12,000 are hip fractures. So it's very significant. The piece I want to mention here is that, yes, men do get osteoporosis. I think there's this myth out there that osteoporosis is a disease of older women, that men don't get it. And yes, men do get it. And men often have a more difficult time with osteoporotic fractures. So we really need to make sure men are well aware that they need to investigate and look after their bone health. So what is an osteoporotic fracture? So that's a fracture or broken bone that occurs for different reasons that really it shouldn't have happened. So spontaneously, so we don't know, it happens, especially a spine fracture or vertebral fracture, as a result of normal daily activities. So to give you some examples, picking up the groceries, a grocery bag, making the bed, lifting a turkey out of the oven at Christmas time. We've seen fractures of the spine, moving objects, often, people lifting something like shifting a table maybe or a chair, they'll see something, they may have a fracture that way. So things that people do regularly that are normal activities. And so if somebody has a fracture from that, they really need to investigate what's going on with their bone health. From low trauma, so such as a fall from standing height or less. So this is important because this is not someone falling off a ladder. This is somebody who's standing height, feet are on the floor, they've tripped, they've slipped, they put their hand out, they break a wrist, or they fall backwards and, break their hip. That's a low trauma fracture that we need to investigate what is happening with that person's bone health. So very important that things that that shouldn't have caused a fracture, we need to investigate it. So the fragility fracture is the most serious sign of osteoporosis, and we need to investigate that. So the consequences of a hip fracture. I call a hip fracture a hip attack. It is as serious as a heart attack. And so one of my surgeons I work closely with, he says to his patients, you've had a hip attack. We need to make sure we do something to prevent another fracture. So the consequences of a hip fracture, are absolutely life-changing, quality of life changing. And you'll see here on the slide that 28% of women and 37% of men will die from the complications of a hip fracture the following year. That's huge. And hip fractures can be prevented, and I'll talk about that in a few minutes. So when we see these stats, they're just mind-boggling to me, and this is what really drives me in my work, is we can prevent hip fractures. And when we see these staggering numbers, we need to all work hard to help the people we love and that we work with to prevent fractures. The hip fractures also result in a long hospital stay, especially for our older adults or the frailer adults. They stay much longer recovering. And the cost of a hip fracture to the Ontario healthcare system is about $64,000 each. So cost is huge for the healthcare system, but the biggest piece is the quality of life and how it changes things and changes somebody's it really becomes the tipping point for somebody who was living in their home to have to be institutionalized in either a hospital or a long-term care home. People living, so something that's important to note too, especially for there's many of people on the call today are working with people living with dementia, and people living with dementia are up to 3 times more likely to than an older adult without dementia to have a hip fracture. So again, really important for all of us on the call today to be thinking, how can we, help the people that we love and work with prevent fractures. So spine fractures, they're also very they're also very devastating as well. They are fractures of the spine, also known as compression fractures. They can lead to a loss of height, a rounding of the back, or kyphosis, and can cause shoulder pain as well. So vertebral fractures frequently go undiagnosed until there's pain or an observed loss of height, or sometimes they may be diagnosed as a pulled muscle. 2 out of 3 spine fractures have no pain, so they're asymptomatic. So they're the sneaky ones that people don't know that they've had until sometime later they will see some height loss. So you'll see in this picture how somebody over their time has had one fracture, spine fracture, and then another, and they you start to see that skeleton or that person's body shape change. And the risk of suffering a second spine fracture within the year following the first one is 20%. So we consider that a very high risk of having another fracture. So people who have had a spine fracture need to be looking at interventions to reduce that. And I'll talk about those when I get to the guidelines. 1 in 6 people with a spine fracture will die within 5 years, and that's because of the quality of life impact that that person is dealing with. That skeleton on the far right side, you'll see that their stomach is protruding, their rib cage is sitting on their pelvic bone, on their hip bone, and eating, sleeping, all of those things are impacted. Multiple spine fractures may severely impact the quality of life. And I say may, and it really does impact the quality of life. So there's a post-fracture osteoporosis care gap. This is why the Ontario Osteoporosis Strategy was put into place, because we know that although we have BMD testing or bone mineral density testing and coverage for osteoporosis medications, etc., we know that 80% of fracture patients never are offered screening and or treatment for osteoporosis post-fracture. So this because of this, it causes people to have another fracture or recurrent debilitating life-threatening osteoporotic fractures. So when we look at 50% of hip fracture patients, they actually told the healthcare system that they were coming. They had already experienced a prior fracture. So this is huge because when we look at the Simcoe Muskoka area, we have about 750 hip fractures every year in this area. So almost 50% of them had already had a fracture, already said, "Hey, look at me. There's something wrong with my bone health." And the interventions weren't put into place to help them prevent the next fracture. So we really need to be not only preventing the first fracture, but if somebody has had a fracture, preventing that next fracture. One of the reports that I've seen out related to dementia is that persons with dementia are often not treated for osteoporosis. So that's been in documented reports through the UK, et cetera. And so again, that's a group who we already know are at higher risk of having a fracture, a hip fracture, than people without dementia. So again, we have to look at fracture prevention and making sure we embed that in everything that we do. So the clinical guidelines that came out in October. Now, I'm only going to kind of buzz through these really, really quick. There is a great webinar coming up on April the 25th by the main author of the guidelines, Dr. Suzanne Moran. And there'll be more information coming out in a package to you about how to sign up for that webinar. So these guidelines are they came out in October. They are to assist Canadian primary healthcare professionals in screening community dwelling postmenopausal females and males age 50 and older for the presence of risk factors for osteoporosis and fractures. And it gives interventions to optimize skeletal health and fracture prevention. So you'll see if you've had a chance to see these recommendations, they're in an algorithm that looks like this. The initial ones, which are really important for all of us on the call today, is really that anyone over the age of 50 should be looking at balance and muscle strengthening exercises more than twice weekly. Suggest eating foods rich in calcium and protein, and suggest a minimum vitamin D supplement of 400 international units daily. So those I'm going to get into right now, and then I'll come back to some risk factors in a moment. So related to calcium, Osteoporosis Canada strongly recommends obtaining calcium from food sources whenever possible. So it's important to eat a well-balanced diet that has calcium and protein. And if your diet is giving you enough calcium, then you do not need to take extra supplements. And that's really important because it's one less thing. If people are getting it in food, then they don't need to take it in a supplement format. So how much does somebody need? So if we're all working with that over 70 crowd, for instance, 1,200 milligrams of calcium is what men and women need. If men are between the ages of 51 and 70, they're looking at 1,000 milligrams of calcium. How do we know if we're getting enough calcium? There are some tools available on our website. The osteoporosis calcium calculator helps give you an idea of what your daily calcium intake is. So it's a great tool. So if you're getting enough calcium in your diet, then you don't need to have a supplement. So vitamin D, it helps build stronger bones by increasing the absorption of calcium. And Health Canada recommends daily vitamin D supplementation of 400 international units. So for bone health, we look at, for men and women over the age of 70, at 800 international units. So it's very difficult for many of us to get vitamin D in food because you can get it in milk and eggs, etc. But it's to get that amount of vitamin D. So really, we know that 400 international units should be taken in supplement form. So many people will look at that getting a supplement of, depending on that age group, for that. If you're over the age of 70, then they're looking at that 800 international units. But it's important that they talk to their family doctor, their nurse practitioner, to make sure that they're getting the amount that is right for them. It's important that especially if people have osteoporosis and are seeing a specialist, there'll be a very individualized recommendation for them. Exercise and movement, the big new message around exercise and movement is really around balance, functional, and resistance training more than 2 times weekly. So balance is really important. There's a great webinars I've sent in the package that you'll be receiving, lots of information on the exercise and movement guidelines. But again, really actively looking at least 2 times a week with intensive balance and functional and resistance training. So as we go into the risk factors, the clinicians want to look and identify what risk factors would be something that would cause somebody to have a fracture. And so on this list, you'll see the risk factors and signs of possible vertebral fractures. And over on, I've just blown this up a little bit bigger so you can have a look. So the list is really around, has that person had a fracture before? Are they on steroids, especially prednisone? Falls, more than 2 falls in the last year. The parent has had a hip fracture. Their parent had fractured their hip. BMI that's really low. Secondary osteoporosis, current smoking, and alcohol, 3 or more drinks per day. So the clinician will look at those risk factors, and all of us need to look at those risk factors. Do we have any of those risk factors? And then that determines whether we need a bone mineral density test. And that will help do a fracture risk assessment. So just to give you if you're working with somebody over the age of 70, if they have not had a BMD done, then, and they don't even need a risk factor, they should be having a bone mineral density test completed and a fracture risk assessment completed so that they can, to make sure that they know what their 10-year fracture risk level is. Somebody that, let's say, is 68 with 1 risk factor, so if they've had 2 or more falls, or if they're a smoker, so one of those risk factors in that age group, and that age group of 50 to 64, they need to have had a previous fracture or 2 or more risk factors. That helps, that BMD calculates a 10-year fracture risk using a Frax or Keroc tool. And so that's really important as we look at what level is a fracture. The signs of possible vertebral fractures, again, clinicians will look at, has there been any height loss and their rib to pelvis distance, etc. Signs of a new spine fracture, again, they're sneaky. So if there's no pain, sometimes the pain is often the trigger that gets us to talk to the family doctor or go to emerge. But sometimes we see other things. So if there's I just wanted to highlight here about behavior changes. If somebody has, if you've seen some behavior changes with people that you are working with, or the family has talked about some changes. Again, if somebody is nonverbal, they can't express pain, they may or should be investigated for things like possible spine fracture, especially if they can be, again, something that we don't think about, and we're thinking about other things that have caused that behavior. So fracture risk. So once we get the fracture risk level, and if somebody's at high risk, they need to be, they will be recommended drug treatment for osteoporosis. And again, more details on this will be available in that resource package. So as we look at long-term care recommendations, they are slightly different. There's a great package that was developed by Dr. Alexandra Papiano and her team at Jairus. And we want, the reason that she did this work is that fractures are the most frequent reason for hospitalization of long-term care residents. So we can't forget that people in long-term care need to have good care, and these recommendations are what they would follow. There's fracture risk scale. I just want to mention really briefly about it. It's a scale that's used in long-term care to identify people who are at high risk of having a fracture. So the 10-year fracture risk tools that I mentioned earlier, which was the Keroc and Frax that they use with BMD. If you're living in long-term care, if you say to someone, well, your 10-year fracture risk is this, that's not, that's not helpful to somebody who's 93 years old, we need to know what is their chance of having a hip fracture within a short period of time, like within the next year. So this tool is an excellent tool to help guide us in long-term care to identify people who are at high risk and put interventions in place. There's a tool that has been developed similar to long-term care fracture risk scale, which is the home and community care tool. It's coming this year. It's available in paper version now, but will be embedded into the RIDE tool for home and community care coming. Falls and fractures, I just want to mention that again, lots of people fall, not everybody fractures. Why did they fracture? We need to investigate that. And we need to look at this as a very integrated system when we look at falls and fractures. Again, great research and work and approaches in other countries and around dementia, falls, and fractures. I mentioned this at a conference a couple years ago. Dr. Paul Mitchell is an excellent expert in this field, and and this document is excellent. And again, it's been shared in the resource package. There's lots of other integrated approaches that we can look at in embedding fracture risk assessments. Some of the stuff that we're doing in this region, we have fracture screening and prevention programs in hospital. We have post-fall pathways where we've embedded fracture risk assessments. Some of the work that my hope is looking at the Ontario Health Team's integrated chronic disease pathways, something like COPD, where we know that if the person is smoking or if the person's on prednisone, that one risk factor or those two risk factors, if for both, would be a reason to put somebody to encourage somebody to have a fracture risk assessment. We've got memory clinics where we could embed fracture risk assessments, etc. So those integrated approaches are really important. So it's my takeaways for today. There's lots of information. I've gone through this pretty fast. I'm always available to connect with you. It's never too late to encourage older adults that you work with to look after their bone health and do something about their bone health. We need an integrated approach in caring and supporting older adults. And preventing fractures is not one person's responsibility. It's not Monica's job or somebody else's job. We all need to work together to achieve excellent care and embed it in the work that we're doing, because those fractures are that slippery slope or the tipping point for making somebody that was independent need the care and not be able to age well. Risk factors for fracture, we think about those ones that I mentioned, encourage people to have fracture risk assessments. Again, if they have no risk factors over the age of 70, then they still need to go. But most of us are seeing people that have multiple risk factors. So again, encourage them to talk to their family doctor, their nurse practitioner. Lots of evidence-based information and resources, and preventing fractures is possible. We can make a difference and help people age well. And I'm just going to put it over to questions. I know, Stephanie, I'm probably pushed the 9 o'clock button pretty close.
No, it's all okay. Thank you, Monica, for such a fabulous presentation with lots of very, very great information, giving us lots to think about. I'm not seeing any questions in the question box or in the chat box, but yeah, Jackie has put in the chat the resource that Monica's been talking about, just a little package. I do encourage everyone in the call to check it out. There's some really, really amazing stuff in there. And of course, as Monica has mentioned too, if you have any questions, Monica is available and her email is in the package. I will just quickly, before everyone gets on with their day, just highlight that we do have our May practice short occurring on Friday, May 10th. We do have Laura Bates and Lori Gill from the North Simcoe Muskoka Palliative Care Network presenting, and they'll be discussing assessing pain in those who can't tell you. So we're looking forward to that presentation. And then we do have some regional education happening. So we do have GPA occurring April 24th in Bracebridge, and as well as Positive Approaches to Care occurring May 22nd in Aurelia. So for any more information about those educations or anything upcoming or to register, please go to the Specialized Geriatric website for more information. So again, thank you, Monica, for that fabulous presentation. And I hope that everybody has a fabulous Friday and hope to see you all in May.